who is working at the ULB Children's Hospital in Clean Fibrosis. And the title of this lecture is Looking Forward and Moving On, Transitions from Pediatric to Adult CF Care.
Dear colleagues, ladies and gentlemen, I would like first to apologize Professor Dirk Matthijs. He is not there for medical reason, and we chose with Christian Knop, who is pulmonologist at Erasmus Hospital for the University of Brussels and who works with me since more than 15 years on the transition from the pediatric clinic to the adult clinic to present our experience today. As you know, cystic fibrosis is a very complex systemic disease involving many organs, lung, pancreas, gut, ENT sphere, but also male fertility. And you see in the first presentation that there is about one birth on 2,500 births in Caucasian population. And the genetic defect is now well known since 1989, and it's the cystic fibrosis transmembrane conductance regulator. And we know that there is more than 2,000 mutations, but the most important is the mutation 508. In Belgium, we are following more than 1,000 patients in 7 centers and in 5 big cities. As you know, also there is a very important increase in the midlife expectancy from 15 years to 45 now. And there is still a bad prognosis for females, probably because of the inflammatory disease. The inflammation is more important in females with more important recruitment of neutrophils, and there are collateral damage in tissues in females, and this is true in other inflammatory disease. Thus, there are more and more patients that are coming to adolescence and then to adulthood with a very good function, and there is an increase in the FEV1 in more and more patients, and you see here in adult patients that about 30% of the patient and even 40 have a good function at the adulthood. Now it's important to organize the transition between the pediatric team and the adult team. And it's very important because it's just during a specific period, the adolescence. This is a process of transition, and this is very difficult sometimes, especially when chronic disease adds to the complexity of this period. Difficulties because of the puberty, because of the development of autonomy of the patient, personal identity, the sexuality, but also different educational and vocational choices that can be influenced by physical impairment, by medical setbacks, by pain, by forced dependence, and also that can be perceived with bad prognosis. This is very important to organize it. And the organization of the transition is not only the transfer of the responsibility to the adult team. It's a long time process with a timeline proposition to the patient and to the family. This is the supplant movement of adolescent and young adults with chronic medical illness from child-centered to adult-oriented healthcare system. And it's very important to organize it to provide an optimal healthcare with no interruption of the treatment, with a good coordination, especially with paramedicals. The development and the nutrition of the young adults is also very important. Psychosocial sound and comprehensive information. And this is the reason why everywhere in the developed countries the team, especially the pediatric team in the beginning, are developing programs of transition. And there are clear positive impacts of active transition program. This is a good means to give sense of responsibility and personal control for the patient. But also, this is a good means to improve decision making in progressively shifted from the parents to the adolescent and then to the young adult. And we must give strong message. Care will be permanent issue. It's sometimes very difficult in adolescent, and you will survive. And it's really the case now with very fascinating treatments that are now available. There are also potential risk and negative impact to maintain the patient in the pediatric ward, especially the discussion of critical adolescent issue could be neglected. Sexuality, reproductive health, substance abuse and risk behaviors, vocational counseling and independent living. This is very important. The difference with peers is emphasized and must be also one of important things to be discussed with the patient. And there is a danger to give incorrect message to this patient. Transition is also very dependent from the perception of the team. Not only the director of the team, director of the adult team, of the pediatric team, but also the perception of all the team, the psychologist, the nutritionist, the dietist, the physiotherapist. And there are some survey on this problem, and this is very interesting to note that a few years ago there was really a lack of competent adult CF physician to take the patient in treatment. But now there is fortunately an improvement in this problem, and all the centers have good adult team to take the patient. But it remains really true for other chronic disease, especially as this was presented just for the patient with cancer, but also for patient with metabolic disease, also for patient with genetic disease. It's very important to put together the adult specialist and the pediatric team to organize gradually the transition. What are the reasons for transfer? Usually age of the patient in more than 80%, but sometimes emergency as pregnancy. And there are also sometimes bad reasons to not transfer the patient to adult center. Patient and family resistance, sometimes with the agree of the pediatrician team, disease severity or developmental delay. And when you analyze the perception of the pediatric and the adult team, you see that for the adult team there are strong relation with the pediatric staff, and it's very difficult sometimes to organize a strong relation very quickly with the adult team. Because in adult consultation, this is another kind of relation with the patient. And for the pediatrician, they are afraid that the patient were not well cared, and we must, as pediatrician, give to the adult staff also all the information according to the records of the patient, the complication, and help the adult staff to be helpful and efficient in terms of medical, developmental, and emotional planning. Thus, ratings of success of transition programs were inversely calculated in the literature with pediatricians' concern about adult staff meeting patients' medical and emotional needs. Now, this is also one thing that is very important, is the perception of the patient. And as you see here, this is some sentence coming from a patient. I was 90 when I transitioned, and it was a huge shock. My pediatric doctor was amazing. My mom was usually with me, but even then, my pediatric doc spoke directly to me and helped prepare me for what was coming. She took so much interest in my life outside of cystic fibrosis as well. She knew that what was going on at home affected my disease. Transitioning to the adult clinic was awful. I felt that my new doctor didn't care about me as a person and that I was just another patient to her. After that first disaster of an appointment, I just retreated into myself. After a few more appointments, we have slowly started to get to know each other, but it's still not the same. My pediatric doctor were like family, and I was hoping that my adult doctor would be the same, especially since I'm always up there and always able to deal with them. Thus, we have to organize the transition with a professional program of information and education for the team and for the family. And there are some experience, as those of University of Alabama, with Scholars Week, with 2 or 4 persons, and the objectives are also the same in all the developed countries. Principal components of hospital home management of young CF adult must be given and explained to the patient. The influence of chronic illness on families, especially the young's transition to independence, and the impact of debilitating complications on young adults' independent function. As you see here, there are some lectures in Alabama University, film, scientific and non-scientific literature, panel of discussion, free time for interview and answer and question for adults and family caregivers. And this is very important to organize that very professionally. There are key aspects of transition that must be always respected. Set functional domains: patient preparation, patient readiness assessment, coordination of services, information transfer, primary and preventive health care, patient follow-up and program evaluation, and finally, transition program self-evaluation. It's always important to have a follow-up of our activity. Finally, it's important to prepare the patient, and as you see here, the patient preparation comports also some domains as involve the family in transition planning, discuss the process of transition, provide a transition timeline. This is very important to the patient, and that can be different from a patient to another. Ask about patient's health goals, assess patient's understanding of the transition process, designate who is responsible for key elements of transition. This is also important. What is the person of the team who is responsible, sometimes more than one person. Schedule a visit focused on transition, provide educational material about transition to the patient. This is all the domain that must be respected to be efficient. Now, whether a patient is independently able to contact team members without relying on family members, when the patient is able to list his medication and function, to perform airway clearance without reminders and supervision, with a plan for and attend clinical visit without family assistance, is autonomous, is ready to transit. And it's important to identify for each patient the condition requiring the emergency care and also the condition to be able to go to the adult care unit. Now, when you modify the treatment of a patient because you modify the team, it's important to follow the patient and to see if there is no exacerbation, if the patient remains in good clinical health. And you can see here that in most of the transitional program, the pulmonary function 12 months before at the moment of the transition and 12 months after remain the same. It's also the case for the presence of bacteria, especially for Staphylococcus or Pseudomonas in the lung. There is only an increase of the number of visits to be able to explain and to have a good transition timeline. What is now our experience in Brussels? Since there's more than 15 years, we ask and we obtain that the pulmonologist, the adult pulmonologist, Christian Knoll, go into the pediatric hospital to make consultation with Laurence Hansen, the pediatrician, to see the patient in transition and to have consultation not only centered on transition, but gradually with a proposition according to the transitional time. And it's with the patient alone and with the patient with her parents, the mother. The transition is gradually prepared and accompanied by a pediatric nurse, which is usually the pediatric nurse who usually accompanies the patient. With consultation together with the pulmonologist and the pediatrician, and also with all the other paramedical team, the psychologist, the nutritionist, the dietist, the physiotherapist, and there are contact and discussion about the records of the patient between all the professionals of the two teams. There is also important to explain formally the procedure of transition, to present all team members and to have consultation with specific adult team members as needed. To visit also the outpatient and inpatient facility of the other department. And to demonstrate to the patient that there is a translation of all the medical records from the pediatric team to the adult team. Transfer the patient after discussion with team, patient, parents about patient limits. And this is also important, even if the pediatrician continue to go to see the patient in the adult ward, to have a formal last goodbye visit with pediatric team. Thus, what can pediatric team do better? Introduce the concept of transition, usually early in the life of the patient. To strengthen the transition program, to fretless, trust the adult team, to transfer efficiently and to follow up on their patient's well-being. What do now the adult team very well? To become aware of transition, actually take the pediatric team into account and talk to them, be a bit more helpful and understanding, furthermore, organize physical encounters with the patient to be transferred and his physician, structure the program, and give feedback to the pediatrician to build trust. Thus, it's a long timeline processes, but it's very important to be efficient and to have a good compliance of the patient and of the family that depends from the confidence in the two team, adults and the child. Thus, in conclusion, this is a process that must be lengthy prepared, ideally between 18 and 21 years, but sometimes quickly, and we have a patient at 16 that begin to enter into processes of transition. It will be better to do the transition in stable medical situation and to transfer efficiently when the patient and the parents are ready. Sometimes it's necessary to push in this direction. A number of tools to be developed and a number of open questions must be also indicated. This is our best of pulmonologists, and we are the best of pediatricians.
Thank you very much for this very interesting discussion on an important topic. I think the transition between pediatric care and adult care, and certainly for diseases who now, fortunately, go on much longer than it used to be. So, are there any questions?
Okay. I had one question or one reflection really about, because when we speak about pediatric and adults, maybe we don't think about adolescence, this very special period. And as a matter of fact, in the field of cystic fibrosis, people do not have a lot of data about this very special period where disease appears, becomes obvious, because patients worsen their nutritional status, their respiratory disease, they have increased burden of therapies. Sometimes also they don't want to, they are not compliant anymore. And our psychologist has made her master, and she's now making her PhD about psychopathology of the adolescents. And what she has shown is that many of our adolescents have high anxiety, self-depression, and we absolutely underestimated, as we underestimated pain, of course, in the previous study. And I think for the transition, we have to account with that. I mean, because this psychopathology also has to deal with the autonomy of the patient. Of course, we want them to be autonomous, but we discussed that a lot with the adult team we work with, Dominique Hubert and Nico Chat. And I think what should be important, and we don't make it either, it's the communication between the psychologists, the two psychologists, that's part of the transition, medical, but also psychology.
We have a platform of the psychologists between the 7 centers, just to obtain this discussion and to improve the approach for each center. And we have now a study in Belgium about the adolescence and the transition, and also about the education of the patient, because there is also a big influence of the socio-economic situation of the family, and especially of the educational degree of the mother. There is an important relation between the educational degree of the mother and the prognosis and the efficacy of the treatment in the child and in the adolescent.
Thank you. Children are very adept at using computers, and they can be somewhat empowering if they control the data that goes into it. I know that we in the United States are wrestling with how to create a medical record that the patient can carry, a personalized medical record. Do you see this playing a role in transition in terms of adolescents being given their medical records on a disc that they can then take to their next doctor, or if they come to the emergency room, they can go to that hospital and and that hospital can access a record, whereas the computers from one hospital to the other may not speak to each other.
I think it's very important. And we have also a conversation together between the patient on the platform of our 7 center. We have just a possibility for the patient to discuss with the psychologist, with the physician of the different team, but also to discuss together in some platform of discussion about their disease, about the problem, and I think that computers are very important also, and to give also education by the mean of presentation that we can give to the patient, because it's very important not only to speak with the therapist, but also to have paper, to have film, to have other means of education available.
Other questions? So I suppose all the different university centers are involved in this type of transition between, which is, I think, very good. Thank you. So